Hello everyone, I am Dr. Shariful Halim and today we are going to talk about idiopathic pulmonary fibrosis. So in this video lecture I will be discussing a case and it will be followed up by a set of differential diagnosis and how to actually differentiate between them, and I'll also talk about the common presentations, common investigations to be done in idiopathic pulmonary fibrosis, and how to manage a case of idiopathic pulmonary fibrosis. And finally, I'll talk about the prognosis. Hopefully, you will like this video as it will be a very short presentation and it will be clinically oriented. Oftentimes, idiopathic pulmonary fibrosis cases are given in USMLE step 1 or step 2 CK. And the common patterns of questions involve an X-ray or a clinical vignette followed by asking about the specific diagnostic test or diagnostic findings, or sometimes relating to some basic information or basic functional studies such as pulmonary function test results in idiopathic pulmonary fibrosis. So hopefully you will enjoy the video, and without further ado, let's start. This is our case. A 60-year-old woman presenting with increasing shortness of breath and dry cough for the last 4 months. So this patient has a pulmonary problem because she has shortness of breath and dry cough. Okay, and as dry cough is a symptom which occurs due to irritation of the nerve plexuses in and around the alveoli, it seems like she might have a disease in the alveoli or around the alveoli. Okay, fine. She doesn't have any history of fever or chest pain. This suggests this that this might not be an infectious disease, so it's unlikely to be a pneumonia. There is no history of smoking, alcohol, or illicit drug use. So smoking sometimes can cause dry cough and sometimes can lead to COPD or emphysema, which might have associated shortness of breath. But in this patient, uh, she does not have any history of smoking. She does not take any prescription medications. That is also a very valuable information, as some of the drugs that are used in treatment of UTI and other chemotherapeutic agents might cause lung fibrosis, which might lead to dry cough and shortness of breath. No history of occupational exposure. That's also a vital information because some occupational exposures, such as coal worker pneumoconiosis and other occupational pneumoconiosis, can have a similar presentation with shortness of breath and dry cough. And there is no history of foreign travel or pet exposure. The vitals reveal an increased respiratory rate of 19 breaths per minute, so the patient is tachypneic, but otherwise it's unremarkable. And general examination reveals clubbing, so the finger is clubbed, meaning that the patient has been hypoxic for a significant amount of time, but no cyanosis is present. This means that hypoxia is present, but it's not very severe, or maybe the patient is anemic, for which cyanosis is absent. Auscultation of the lung fields reveal fine, late inspiratory crackles at the bases. This is a classic description of interstitial lung diseases or diffuse parenchymal lung diseases. So let's talk about the differential diagnosis. Okay, so overall we can see that this patient has symptoms such as dry cough and a shortness of breath, and signs such as clubbing and inspiratory crackles. So this is consistent with diffuse parenchymal lung disease or interstitial lung disease or sometimes you can say idiopathic interstitial pneumonia. So they are all almost the same things, but having different names. Okay, but I think ILD or idiopathic interstitial pneumonia are better terms. They are easier and um, they're more specific because there is damage in the interstitium. So there is inflammation in the interstitium leading to pulmonary fibrosis due to many reasons. And as the patient has multiple features consistent with idiopathic pulmonary fibrosis, this will be our provisional diagnosis or most likely diagnosis. Why? Because which whenever there is an interstitial pneumonia which doesn't have or doesn't seem to have any specific cause or reasons, then most likely this is idiopathic. If we go back to our previous slide, you can see some negative points, such as the patient does not have any history of drugs, no occupational exposure, and there is no other significant medical history, meaning she did not have any other diseases which might lead to a pulmonary fibrotic disorder. So this patient only have some features of idiopathic interstitial pneumonia, which probably does not have any underlying cause. So whenever we don't have any cause or reason, we call it idiopathic. And as the patient has features of pulmonary fibrosis, we call it idiopathic pulmonary fibrosis. But uh, can we be can we be certain that this is surely idiopathic pulmonary fibrosis? No. We should always keep some differentials in the back of our head. So what are those differentials? Number one would be radiation pneumonitis. So this is very unlikely as the patient didn't give any history of cancer such as breast cancer for which she required any radiotherapy. So this is very unlikely. Drugs, as I mentioned, the patient didn't have any significant history of drug intake. So those are the drugs that can lead to interstitial pneumonia. As the patient doesn't have them, it's very unlikely. So, but you have to remember all the names of those drugs, and among them, I think the most important ones would be amiodarone. So always remember that. It's very, very important. Amiodarone. Can you tell me what are the other common side effects of amiodarone? Okay. So if you see the name amiodarone, it has iodine in the middle. So iode. It means it has iodine. And whenever something contains iodine, it can affect the thyroid gland function. So it can lead to increased thyroid function or thyrotoxicosis, or if given in a higher dose, it can lead to an old Jacob effect, leading to thyroid suppression and hypothyroidism. So amiodarone can be a cause of hyperthyroidism and hypothyroidism, and it also causes liver damage. Can you tell me what kind of drug amiodarone is? Yes, it's an antiarrhythmic drug. It has all the typical functions of almost all the groups. So it's a classic antiarrhythmic antiarrhythmic drug. Another important drug would be nitrofurantoin, which is commonly used as a treatment for UTI, especially in women. Sulfasalazine, this is a DMRD or disease modifying antirheumatic drug. And there are some other drugs which are chemotherapeutic drugs, such as bleomycin, busulfan, etc. Phenytoin, which is an anti-epileptic agent. Cyclophosphamide, which is an immunosuppressant. The next group of differential diagnosis would be pneumoconiosis, which are also known as environmental, or better way to say is occupational lung disease. And there are multiple varieties of this condition, such as coal worker pneumoconiosis, silicosis, berylliosis, and biocinosis. So you know that whenever someone works underground at a coal factory or coal mine, he might develop coal worker pneumoconiosis. And silicosis happens in patients in people who work as construction worker or sandblasting, etc. Borreliosis might happen if someone works in, for example, Tesla factory. And bisonosis occurs in someone working in uh, cotton mills, such as garment factories, etc. Other differential diagnoses might include granulomatous disease, such as sarcoidosis, but this is very unlikely in this patient as the patient is older and she is not from an African or African American ethnicity. So you might remember the common demographics for sarcoidosis, which is a young African American woman. Hypersensitivity, maybe, and the big group that belongs to secondary causes such as connective tissue disorders, which are commonly rheumatoid arthritis. Very unlikely in this patient as the patient didn't give any history of joint pain or joint stiffness, especially involving the small joints of the hands. SLE, the patient didn't give any history of a rash or arthralgia. Systemic sclerosis, the patient didn't give any history of tightening of the skin. Mixed connective tissue disorder, probably unlikely. And there are some very uncommon causes such as renal tubular acidosis. Very, very unlikely in this patient as the patient doesn't have any underlying disease or does not take any medications. So those are the differentials that you should always consider before declaring someone as having idiopathic pulmonary fibrosis. Okay, so let's talk about idiopathic pulmonary fibrosis. This is a variety of restrictive lung disease. So this is a type of disease that restricts the lung. It makes the lung smaller. It does not let the lung to expand. This is the commonest variety of interstitial lung disease. And as I mentioned before, idiopathic means you do not have any cause or any etiology. But research has shown that smokers are more likely to have or more likely to develop idiopathic pulmonary fibrosis. And the pathogenesis is fairly simple because if you want to have fibrosis, you must have some inflammation. And probably those inflammation um, stay for a long period of time. So for some unknown reasons, there are repeated inflammations leading to a chronic inflammatory process, which leads to fibrosis by fibroblasts, obviously. And this causes destruction of the architecture of the lung. So fibrosis in the interstitium actually thickens the respiratory membrane. So whenever the respiratory membrane is thickened, there will be a defect in the gaseous exchange. So the oxygen cannot get into the pulmonary arteries, and in the later stages, even carbon dioxide cannot get out from the pulmonary arteries. So here are the signs and symptoms. Obviously, the most the earliest symptom would be dyspnea, and this dyspnea generally happens due to a thickening of the membrane, as I was talking before. And initially, it's present only during severe exertion. But as the disease progresses, the patient have some difficulty in breathing even when he or she wants to run or walk. And ultimately, at some point, the patient develops dyspnea even at rest. So whenever someone has a rest dyspnea, you would consider that he or she has a very advanced disease. And it's often associated with dry cough. And there are some other less important symptoms might be present, such as weight loss, malaise, and arthralgia. And going to the signs, Clubbing is a very early feature, and this happens due to prolonged hypoxia leading to hyperplasia of the tissue in the nail bed. And whenever you auscultate the lungs, you'll find that there will be fine late inspiratory crackles involving both the bases, and that sounds like unfastening of a velcro. That's why it's also known as velcro crackles. Velcro crackles. And in advanced cases, whenever there is extensive fibrosis involving the lung tissue, it will lead to central cyanosis, as the gaseous exchange will be severely hampered, severely impaired, and there would be pulmonary hypertension leading to right heart failure. So let's come to the investigations. Obviously, we start from the blood. As you say, the patient develops dyspnea due to decreased gaseous exchange. So if you do an arterial blood gas, you will find that partial pressure of oxygen will be decreased. And this is more pronounced after having exercise. In the early stages, the partial pressure of carbon dioxide is normal and even may be low due to hyperventilation, as the patient tries to increase the level of oxygen intake by increasing the respiratory rate. This leads to excessive loss of carbon dioxide, causing a low PSA2 or low arterial carbon dioxide partial pressure. But in advanced cases, whenever the fibrosis is so extensive that it impairs both gaseous exchange, so hampering the exchange of oxygen as well as carbon dioxide, it leads to type 2 respiratory failure, whereby you will have low partial pressure of oxygen and a very high partial pressure of carbon dioxide. So whenever you get a ABG with suspected idiopathic pulmonary fibrosis showing type 2 respiratory failure, this is an advanced case. Okay, although blood examinations doesn't give us the clue to the diagnosis, it just assesses the level of pulmonary dysfunction we have. But chest X-ray gives us an idea to what might be the underlying cause. So this is better or more valuable in identifying the diagnosis. So whenever someone has IPF, the lung volumes are obviously decreased or reduced. That's why we call it restrictive lung disease. And obviously there would be some fibrosis, and this is more common in lower zones, so lower lobe or lower zones. And the fibrosis would be seen in X-ray as reticular shadowing, or as Oxford Handbook of Medicine it tells it's written as reticulonodular shadowing. So you might call it reticular shadowing. Most of the books actually writes this specific word for idiopathic pulmonary fibrosis, reticular shadowing. So reticulated or lace-like network, or you can say a reticulonodular shadowing. So some reticles, some networks of fibers, and some small nodules, reticulonodular shadowing. And as the patient develops pulmonary hypertension, you will see some pulmonary vascular congestion, and in exacerbations there might be some ground glass opacities, and in advanced cases there would be a honeycomb appearance of the lung. This is an extra finding that's very uncommon nowadays, because most of the patients present very early to the doctor, and the chest X-ray is done, which only might show some reticular shadowing, and obviously this is followed by some further investigations, including CT scan and pulmonary function test, which leads to a very early diagnosis. So honeycomb lung is present in advanced cases, but we don't see it because we test the patient in a very early time and very early period. Okay, so this is the chest X-ray that's classic for idiopathic pulmonary fibrosis. As you can see, in this X-ray, the trachea is central, the cardiac shadow is almost normal, but this is obliterated by some shadow in the left lower zones. So you can see some reticulated shadows, some lace-like, some branching shadows, branching lines in the left lower zones, and also involving the right lateral and lower zones. So those are the areas that shows the reticular, or you can say reticulonodular shadows. So bilateral, basal, reticular or reticulonodular shadows, which are more evident in the subpleural regions. So you can say that bilateral reticulonodular shadowings in the basal zones and also in the subpleural regions. And you can see that the hilar region is more prominent. After doing chest X-ray, we find the evidence of fibrosis, and if we want to see the fibrosis in a better way, we might do an HSCT, a high resolution CT scan. This is actually the most valuable diagnostic test in practice because this shows the classic pattern of idiopathic pulmonary fibrosis, and this is present as patchy peripheral subpleural basal reticular pattern. So obviously this is the most important part, basal reticular pattern. But in basal, this is the term that you must remember, basal, and also which part of the base? In the periphery. Which peripheral part? Around the pleura, below, just below the pleura. So basal, periphery of the base, and also subpleural region. Actually, we have already seen that in the X-ray. We'll also see that in the CT scan. And in advanced disease, you will see the honeycomb pattern, which may be called the honeycomb cyst. And there would be some traction bronchiectasis, which means that fibrotic bands actually pulls the airways from all the sides, leading to enlargement of the air spaces, enlargement of the bronchus, which is called a traction bronchiectasis. And the honeycomb cyst typically looks like this. So you know the honeycombs, so it would be looking like kind of this. So simply a honeycomb. Okay, kind of like this. Let's see an example. So this is an example. This is an example of HSCT in idiopathic pulmonary fibrosis. You can see this is the cross section. This is the heart. Obviously, this is the upper region. This is the upper mediastinum. Okay, it's part of the upper part of the great vessels and heart, probably. This is those are the bronchuses, and we should focus on the marginal areas. So those are the subpleural regions which are abnormal, which seems very abnormal. Those are the abnormal zones. And you can see there are honeycomb patterns. So those are actually the honeycomb patterns that we classically find in patients with HSCT, in patients with IPF. And those are present in the subpleural regions. Subpleural regions. An important test for any patients having a restrictive lung disease or interstitial lung disease would be pulmonary function test. Why? Because we want to know the functional status of the patient, so we'll be calling it the baseline, and we want to track the progress of the disease. Why? Because we want to tell the patient about the prognosis, because whenever someone have a deterioration of the lung function within a very rapid time, within a very short time, then his or her prognosis would be worse than other patients. So we want to track the patient, see the progress, and tell the patient about it. Okay, so if we do pulmonary function tests in a patient with idiopathic pulmonary fibrosis, we'd obviously find a restrictive pattern, meaning The volumes will be low, so all the volumes, including total lung capacity. Obviously, it's not a volume, it's a combination of volume, it's a capacity, and the volume such as forced expiratory volume in per second or FEV1 and forced vital capacity. All of those volumes and capacities will be lower than normal. But notice that the reduction of FEV1 and forced vital capacity or FVC are almost equal, and sometimes FVC reduction is more than the reduction of FEV1, leading to a normal or increased FEV1 FVC ratio. Do you remember the FEV1 FVC ratio in patients with COPD? Yes. In patients with COPD, the FEV1 reduction is much larger than FVC, leading to a decrease in the ratio of FEV1 versus FEV1 divided by FVC. So in restrictive lung disease, FEV1 FVC ratio is normal or increased. In obstructive lung disease, the FEV1 FVC ratio is decreased. And as the interstitium is fibrosed, the carbon dioxide transfer will be low. So the transfer factor or diffusion capacity of lung for carbon monoxide will be low. And the A gradient will be high because alveolar arterial gradient will be high because there is a barricade in between those two parts, alveoli and artery. In between lies the great wall of fibrotic bands. So that's why the air from the alveoli cannot pass into the pulmonary arteries. So oxygen concentration is higher in the alveoli but very low in the arteries, leading to a very high AA gradient. And one of the tests, which is you cannot say that it's a pulmonary function test, but I've mentioned it because I forgot to include that in the previous slide. One of the tests that you can do is a dynamic test, which is identifying a suspected patient of idiopathic pulmonary fibrosis in a very early stage. So whenever someone comes with a complaint of exertional shortness of breath and a dry cough, you might want to do a dynamic test, which includes telling the patient to do some form of exercise and measuring the oxygen, measuring the partial pressure of oxygen in an ABG sample before and after exercise. And if you see there has been a significant drop of partial pressure of oxygen in after exercise, you would consider that this might be a case of idiopathic pulmonary fibrosis or simply a DPLD. What are the other investigation options? BAL or bronchoalveolar lavage is an option. This is not very valuable. I think this is much less important, but still it can provide us with some um, information which is not available from other investigations. So it can tell us about the alveolitis or inflammation pattern, how much inflammation is going on. So if there is an increase in lymphocyte count, inflammation is going on and it's a good type of inflammation, which means the prognosis is better and the treatment response would be better. But if the level of neutrophils and eosinophils are high, then it's a bad type of inflammation, a bad process is going on, indicating a very poor response to treatment, and the patient has a bad prognosis. What's about a lung tissue biopsy? Actually, this is the most it's the most confirmatory test, or you can say the gold standard for diagnosing the pulmonary parenchymal disease or interstitial lung disease, because you want to see the tissue and you want to identify what's wrong with the tissue. That's the gold standard. But often this is not practical. So if you suspect a case as IPF, and if you see all the classic clinical features ranging from the sign and symptoms and investigation findings such as X-ray, CT scan, and also pulmonary function test, you might not want to do a lung tissue biopsy. But if you have some confusion about the diagnosis, you are not confident enough, you might opt to go for a lung tissue biopsy. And if you want to do a biopsy, you must have to have a big chunk of tissue. So you have to have a surgical or open lung biopsy. But if you have the capacities of doing a video assisted thoracoscopic lung biopsy, you might also do that. And the histological changes for idiopathic pulmonary fibrosis is not 100% specific. The findings are generally grouped under a term which is known as usual interstitial pneumonia or UIP. Now let's talk about management. First of all, there is not much to do for someone having an advanced case of IPF other than giving him or her some support. So this would be the mainstay of treatment, which is the supportive treatment. As the patient has hypoxia, let's give him some oxygen. And if the patient's breathlessness is very uncomfortable, it's very severe dyspnea, doesn't let him to sleep, we might consider adding some opiates, and we must train him how to do the pulmonary exercises, etc. So we'd call it pulmonary rehabilitation. The options for treatment, other treatment or specific treatment would include corticosteroids, which may or may not be added with cyclophosphamide, as high-dose steroid is contraindicated in IPF. So this is not a very good option. A more specific drug that targets the disease process would be porphenidone, because this is an anti-fibrotic drug. It actually decreases the level of fibrotic activity in the lung. So this has shown promise and now used for almost all the patients of ILD or IPF. And we can give it up to 801 milligram 3 times a day, and you have to consider continuing it for the rest of the life. And in hopeless cases, we might go for a lung transplant, but this would require a lot of other factors to be considered. And what's the prognosis of the disease? It depends on many factors, and sometimes we cannot predict the prognosis. But something that helps us in prediction would be a pulmonary function test. So this is something that is valuable for actually counseling the patient about the disease. So we must do some pulmonary function test after certain intervals. Overall, the median survival is around 3 years, but in some cases, patients survive more than 7 years. Even someone can survive 20 years. But in some cases, you might see a patient dies within 1 year. So it's a big range, 1 year to 20 years. This is the range for survival in patients with IPF. And sadly, IPF may be associated with cancer. Okay, this is the end of our discussion. Thank you for watching my video. Please like and subscribe to my channel, and recommend what should I do and what I shouldn't, and what are the other common topics you would like to have some presentations on. Thank you very much again.